Good afternoon, everybody. Today I'm going to walk through a simulated medical record and explain how a clinical exercise physiologist would approach this case. The main goal here is to show how we take patient information, break it down, and decide if exercise testing is safe and appropriate. I'll go step by step through the patient's background, clinical findings, and then explain how those factors influence testing decisions. I'll also touch on contraindications and what kind of monitoring would be needed. This is meant to reflect what we would actually do in a clinical setting where the focus is not only collecting data, but making safe and informed decisions for the patient. So, before getting into the case, I want to briefly explain the role of a clinical exercise physiologist. According to the American College of Sports Medicine, or ACSM, a CEP is responsible for evaluating patients before exercise, identifying risks, and making decisions about testing and exercise prescriptions. So, this includes reviewing medical history, understanding diagnosis, looking at medications, and paying attention to symptoms. It also means knowing when it's okay to move forward with testing and when it's better to hold off or modify the approach. One thing that stands out to me is that this role is really just about judgment. It's not about following a protocol, but also taking all the information you have and deciding what is safest and most appropriate for that specific patient. So, for this case, we have a 62-year-old male with several cardiovascular conditions. He has coronary artery disease, hypertension, and type 2 diabetes. He also had a non-ST elevation myocardial infarction, or NSTEMI, about 3 months ago and has stent placed. Since then, he's been cleared for exercise, but with caution. His lifestyle is mostly sedentary, and he doesn't have much experience with structured exercise. When you look at his overall picture, this is clearly a higher risk patient. He has multiple chronic conditions and a recent cardiac event, which means we need to be very careful with how we approach exercise testing. Now, looking at the clinical data, there are a few things that stand out right away. His resting blood pressure is 148 over 92, which is still elevated. His resting heart rate is 78 beats per minute, and his oxygen saturation is normal at about 96%. His ejection fraction is 45%, which tells us that his heart's pumping ability is slightly reduced, which means it's just not severely low, but it does show some level of dysfunction. His HbA1c is 7.8, which indicates that his blood sugar is not very well controlled. On top of that, his ECG shows occasional premature ventricular contractions, which are abnormal heartbeats. He's also taking a beta blocker, which is important because it will lower his heart rate response during exercise. So we can't rely on heart rate alone to justify his intensity. So when you put this all together, it shows that the patient is stable, but still has multiple factors that increase his risk during exercise. So from a functional standpoint, the patient reports fatigue and shortness of breath with activity. Even things like climbing stairs or walking longer distances can be difficult. This tells us that his exercise tolerance is low and that he's likely deconditioned. This is pretty common in patients with cardiac conditions, especially after an event like an NSTEMI. His goals are to improve endurance, lose weight, and become more active. Those are all appropriate goals, but we have to make sure we approach them in a way that doesn't put him at risk. So this is where we start thinking about how his current limitations will affect testing and exercise prescription. So next, I then looked at contraindications based on the ACSM guidelines. The good thing is that this patient does not have any absolute contraindications, so there's nothing that completely prevents exercise testing. However, there are several relative concerns. His blood pressure is elevated, he has occasional arrhythmias, and his ejection fraction is very reduced. So these don't mean that we can't test him, but they do mean we need to be more cautious. So this is where clinical judgment becomes very important. Instead of just asking, can we test him? The better question is, how can we test him safely? And that usually means modifying the protocol, increasing monitoring. So, based on all of that, the best option for this patient would be a submaximal exercise test. A maximal test would likely place too much stress on his cardiovascular system right now, especially with his recent cardiac history and current limitations. A submaximal test allows us to get useful information about his fitness level and about how his body responds to exercise without pushing him to his limit. Another important factor is his beta blocker use. Since his heart rate response will be lower than expected, we would also rely on things like perceived exertion and symptoms to guide intensity rather than just a heart rate number alone. So, overall, this approach gives us a way safer way to reevaluate him while still collecting meaningful data. Monitoring is a big part of this process as well. For this patient, we would use continuous ECG monitoring to watch any abnormal heart rhythms. We would also check blood pressure at each stage of the test and monitor perceived exertion throughout. At the same time, we need to watch for any warning signs. So this includes chest pain, unusual shortness of breath, dizziness, or abnormal ECG changes like ST depression. If any of these things happen, the test should be stopped right away. So this is really where the CEP plays a critical role in this role. It's not just about running the test, but also constantly evaluating how the patient is responding and making decisions in real time. There's also important ethical responsibilities to consider. First is patient privacy under HIPAA. All patient information has to be handled carefully and kept confidential. Then there's informed consent. Before testing, the patient needs to understand what the test involves, what the risks are, and what to expect. OSHA also plays a role in making sure that the testing environment is safe. And on top of all that, as a CEP, it's also important to stay within your scope of practice, document everything clearly, and communicate with other healthcare providers when needed. These may seem like basic things, but they are very essential for safe and professional practice. So, to wrap everything up, this patient is not appropriate for maximal exercise testing at this time. However, he is appropriate for supervised submaximal testing with close monitoring. The key takeaway here is that a clinical exercise physiologist has to balance risk and safety with every decision. And it's not just about running tests, but also understanding the patient and choosing the safest way to move forward. In this case, careful evaluation, modified testing, and close monitoring allows us to assemble and assess the patient while still protecting their health. It'll be supervised submaximal testing that would be the preferred method to go about. Thank you.